Welcome to today's lesson on how body shapes can reveal underlying hormone imbalances. This is a fascinating intersection of endocrinology, metabolism, and clinical diagnosis. Before we explore body shapes, let's understand the endocrine system. The endocrine system is a network of glands that produce and secrete hormones directly into the bloodstream. The major endocrine glands include the hypothalamus and pituitary in the brain, the thyroid gland in the neck, the adrenal glands above the kidneys, the pancreas, and the reproductive organs or gonads. So what exactly is a hormone? A hormone is a chemical messenger that travels through the bloodstream to target organs and tissues, where it regulates specific physiological processes. Hormones regulate everything from metabolism and growth to reproduction and mood. They are essential for maintaining homeostasis in the body. When hormone levels become imbalanced, one of the most visible manifestations is changes in body composition and fat distribution patterns. Here's an important question. Why does fat distribution matter for health? Why should we care where fat accumulates on the body? The answer is that different fat depots have different metabolic activities. Visceral fat, which surrounds internal organs, is metabolically active and produces inflammatory cytokines. Subcutaneous fat, the fat beneath the skin, is generally less harmful than visceral fat. The location of fat accumulation can predict disease risk. Let's examine the first major body shape pattern, the android or apple shape. This pattern is associated with elevated cortisol levels. The android shape features central or abdominal obesity with fat accumulating around the midsection, while the limbs remain relatively thin. This is the classic stress hormone body shape. Cortisol is produced by the adrenal glands in response to stress. It's part of the hypothalamic pituitary adrenal axis, or HPA axis. Cortisol increases blood glucose levels by promoting gluconeogenesis in the liver. It also promotes fat storage, specifically in the abdominal region, while breaking down muscle tissue in the limbs. Chronic psychological stress, sleep deprivation, or Cushing's syndrome can lead to persistently elevated cortisol levels and this characteristic body shape. Normally, cortisol follows a diurnal rhythm, peaking in the early morning around 8 a.m. and declining throughout the day. In chronic stress or Cushing's syndrome, this pattern is disrupted. The second major pattern is the gynoid or pear shape, associated with estrogen dominance or excess estrogen relative to progesterone. The gynoid shape features fat accumulation in the hips, thighs, and buttocks, with a relatively narrow upper body. This pattern is more common in women but can occur in men with hormone imbalances. Estrogen promotes subcutaneous fat storage, specifically in the gluteofemoral region. This is an evolutionarily conserved pattern related to reproductive function. Causes of estrogen dominance include polycystic ovary syndrome, or PCOS, perimenopause, obesity, which increases aromatase activity, and exposure to xenoestrogens from environmental sources. Let's ask, how does estrogen differ from progesterone in terms of metabolic effects? Why does the balance between these hormones matter? Estrogen promotes cellular proliferation, fluid retention, and fat storage in specific depots. It's anabolic for certain tissues. Progesterone has anti-estrogenic effects, promotes thermogenesis, and has mild diuretic properties. The balance between these hormones is crucial for metabolic health. The third pattern is associated with hypothyroidism, or low thyroid function. This creates a generalized weight gain pattern. Hypothyroidism causes generalized weight gain without a specific pattern, along with fluid retention, giving the body a puffy appearance. This is accompanied by fatigue, cold intolerance, and slow metabolism. Thyroid hormones, specifically T3 or triiodothyronine and T4 or thyroxine, regulate basal metabolic rate. They control how fast your cells burn energy. Basal metabolic rate is directly proportional to T3 concentration. When T3 is low, metabolic rate decreases and weight gain occurs even with normal caloric intake. Hypothyroidism reduces lipolysis, which is fat breakdown, while increasing lipogenesis, which is fat synthesis. It also causes sodium and water retention. This graph shows the relationship between thyroid hormone levels and metabolic rate. As thyroid hormones decrease, metabolic rate drops proportionally, leading to weight gain. The fourth pattern is associated with insulin resistance and metabolic syndrome. This features prominent abdominal obesity with a large waist circumference. Insulin resistance creates prominent visceral adiposity with a large waist-to-hip ratio. This is the most dangerous pattern metabolically, associated with type 2 diabetes and cardiovascular disease. Let's define this clearly. What exactly is insulin resistance? How does it develop, and why does it cause this specific fat distribution? Insulin resistance occurs when cells, particularly muscle and liver cells, don't respond properly to insulin. The pancreas compensates by producing more insulin, leading to hyperinsulinemia. High insulin levels promote fat storage, particularly in visceral adipose tissue, while simultaneously inhibiting lipolysis. It's a fat storage hormone. This graph compares normal insulin response in green versus insulin resistance in red after glucose intake. Notice the insulin-resistant individual has much higher and more prolonged insulin elevation. The fifth pattern is associated with growth hormone deficiency in adults. This creates increased abdominal fat with reduced muscle mass. Growth hormone promotes lipolysis, especially in visceral fat, and stimulates protein synthesis in muscle. When deficient, you get increased fat mass and decreased lean body mass. Growth hormone secretion peaks during deep sleep stages. Chronic sleep deprivation can lead to growth hormone deficiency patterns even without pituitary disease. This represents growth hormone secretion during different sleep stages. The tallest bars represent deep sleep when growth hormone secretion is maximal. In men, low testosterone creates a specific pattern: increased abdominal fat, reduced muscle mass, and sometimes gynecomastia or breast tissue development. Low testosterone in men leads to increased central adiposity, decreased muscle mass, and sometimes breast tissue growth. Testosterone normally promotes muscle synthesis and fat oxidation. Testosterone is powerfully anabolic for muscle tissue. It increases protein synthesis and decreases protein breakdown. Low levels result in sarcopenia or muscle loss. Here's an important question. How does aromatization, the conversion of testosterone to estrogen, affect body composition in men? Aromatase enzyme converts testosterone to estradiol. In obesity, adipose tissue has high aromatase activity, creating a vicious cycle. As men gain fat, especially visceral fat, aromatase activity increases. This converts more testosterone to estrogen, further promoting fat gain and creating a positive feedback loop. So how do we actually measure these hormone imbalances and assess body composition? Let's discuss the clinical approach. Waist-to-hip ratio is one of the simplest screening tools. A ratio above 0.9 in men or 0.85 in women suggests android obesity and metabolic risk. Waist-to-hip ratio equals waist circumference divided by hip circumference. This provides information about fat distribution patterns. Blood tests can measure specific hormone levels: cortisol with dexamethasone suppression test, thyroid function with TSH, free T3 and free T4, fasting insulin and glucose, testosterone, estradiol, and growth hormone with IGF-1 as a marker. Dual energy X-ray absorptiometry or DEXA scan provides precise measurements of fat mass, lean mass, and bone density in different body regions. This table summarizes normal hormone ranges and body composition changes associated with high or low levels. Notice how each hormone creates a distinct pattern. It's important to understand that these hormones don't work in isolation. There are complex interactions, particularly between cortisol and insulin. Cortisol raises blood glucose through gluconeogenesis. This triggers insulin release, and chronic cortisol elevation can cause insulin resistance. Both high cortisol and high insulin promote central fat accumulation. This is why metabolic syndrome often involves both systems. This diagram shows the bidirectional relationship between cortisol and insulin. They amplify each other's effects on visceral fat accumulation, creating a synergistic problem. We should also discuss leptin and ghrelin, the hunger and satiety hormones that affect body composition. Leptin is produced by adipose tissue and signals satiety to the brain. In obesity, leptin resistance develops, similar to insulin resistance. Ghrelin is produced by the stomach and stimulates appetite. It peaks before meals and drops after eating. Sleep deprivation increases ghrelin and decreases leptin. This graph shows ghrelin levels throughout the day. Notice the sharp peaks before typical meal times at breakfast and dinner, then rapid drops after eating. Let me present a clinical case to tie this together. A 45-year-old woman presents with progressive weight gain over 2 years, primarily in the abdomen. She reports fatigue, difficulty losing weight despite diet and exercise, poor sleep quality, and high stress from her job. Physical examination reveals waist-to-hip ratio of 0.92, blood pressure 140/90, and acanthosis nigricans on the neck, suggesting insulin resistance. Laboratory testing shows fasting glucose 118 mg per deciliter, fasting insulin 28 microunits per milliliter, HbA1c 6.1%, morning cortisol elevated at 28 micrograms per deciliter, and TSH slightly elevated at 5.8. This table summarizes her results. She has evidence of insulin resistance, elevated cortisol likely from chronic stress, and subclinical hypothyroidism. Multiple hormone systems are involved. So what's the appropriate treatment approach for this patient with multiple hormone imbalances? Treatment must be multifaceted. First, address insulin resistance with metformin and lifestyle modification. Second, stress reduction techniques to lower cortisol. Third, consider thyroid hormone replacement if free T4 is low. Lifestyle interventions are crucial. Low glycemic diet to improve insulin sensitivity, resistance training to build muscle mass, stress management with meditation or yoga, and sleep hygiene to normalize cortisol and growth hormone. Let's discuss a specific condition, polycystic ovary syndrome, or PCOS, which creates a distinct hormone profile and body shape. PCOS is characterized by insulin resistance, elevated androgens, including testosterone, irregular menstrual cycles, and a specific pattern of fat distribution. PCOS creates a mixed pattern, both central android obesity from insulin resistance and gynoid fat from hormonal imbalance. Women may also have hirsutism, or excess body hair from high androgens. In PCOS, high insulin directly stimulates the ovaries to produce more androgens. This creates a vicious cycle of worsening insulin resistance and hormone imbalance. Now let's discuss prevention and potential reversal of hormone imbalance-related body shape changes. Early intervention is crucial. The longer hormone imbalances persist, the more difficult they are to reverse. Body composition changes become more entrenched over time. Caloric restriction and weight loss improve multiple hormone systems simultaneously, increases insulin sensitivity, reduces cortisol, improves leptin sensitivity, and may increase growth hormone pulsatility. Exercise has powerful effects independent of weight loss. Resistance training increases muscle mass and insulin sensitivity. High-intensity interval training improves growth hormone secretion, and regular activity reduces cortisol. This graph shows the typical timeline for body composition improvement with intervention. Notice there's rapid initial improvement in the first few months, then slower continued progress. When addressing hormone-related body shape changes, it's important to monitor more than just body weight. Measure waist circumference monthly. This is often a better indicator of metabolic improvement than total weight. Track body composition with DEXA scans, or bioelectrical impedance. You want to see fat mass decreasing and lean mass maintained or increasing. Recheck hormone levels every 3 to 6 months to assess whether interventions are working. Hormone normalization should precede or accompany body composition changes. Age plays a crucial role in hormone-related body composition changes, particularly in women during menopause. During menopause, declining estrogen causes a shift from gynoid to android fat distribution. Women who previously stored fat in hips and thighs begin accumulating abdominal fat. Both men and women experience declining growth hormone and, in men, declining testosterone with age. This contributes to sarcopenia and increased fat mass. This graph shows the decline in sex hormones with age. Notice the sharp drop in estrogen during menopause around age 50, and the gradual decline in testosterone in men starting around age 30. It's important to recognize that genetics and ethnicity influence both hormone levels and body fat distribution patterns. South Asian populations, for example, have increased risk of insulin resistance and diabetes at lower BMI levels, with more visceral fat accumulation. Genetic polymorphisms in genes like FTO, MC4R, and others affect appetite regulation, fat storage, and hormone sensitivity. Let me summarize the key diagnostic patterns we've covered that link body shapes to specific hormone imbalances. Android or apple shape with central obesity suggests high cortisol from chronic stress or Cushing's syndrome or insulin resistance and metabolic syndrome. Gynoid or pear shape with lower body fat suggests estrogen dominance, often seen in PCOS or perimenopause. Generalized weight gain with puffiness suggests hypothyroidism with low T3 and T4. Loss of muscle mass with increased abdominal fat suggests low testosterone in men or growth hormone deficiency in either sex. Here are some clinical pearls for healthcare practitioners evaluating patients with body composition concerns. Always measure waist circumference and calculate waist to hip ratio. This simple measurement provides valuable metabolic information beyond BMI. Consider hormone testing if a patient's body shape and composition don't match their reported diet and exercise habits. This suggests an underlying endocrine issue. Look for clustering of symptoms. Fatigue with central obesity suggests cortisol or thyroid issues. Hair loss with abdominal fat in men suggests low testosterone. Cold intolerance with diffuse weight gain suggests hypothyroidism. Screen for metabolic syndrome with fasting glucose, lipid panel, and blood pressure in anyone with central obesity. Early intervention prevents progression to diabetes. Emerging research shows that the gut microbiome influences both hormone levels and body composition. The gut microbiome affects estrogen metabolism through the estrobolome, influences cortisol through the gut-brain axis, and affects insulin sensitivity through inflammatory signaling. Dysbiosis, or microbial imbalance, has been linked to obesity, insulin resistance, and altered hormone metabolism. Probiotic interventions show promise but need more research. In conclusion, body shape assessment is a valuable clinical tool that can reveal underlying hormone imbalances. While body shape provides important diagnostic clues, laboratory testing is essential for confirming specific hormone imbalances and guiding treatment. Effective treatment requires addressing root causes, lifestyle factors like stress, sleep, diet, and exercise, plus targeted hormone replacement or modulation when appropriate. The future of managing hormone-related body composition changes lies in personalized medicine that considers individual hormone profiles, genetic factors, and metabolic characteristics. Remember that early detection and intervention offer the best outcomes. The longer hormone imbalances persist, the more difficult they become to reverse.